Welcome, everyone, and thank you for joining us. My name is Molly Felton, and I'm the Senior Specialist of Online Learning here at APIC. The Association for Professionals in Infection Control and Epidemiology and the Leapfrog Group are pleased to present this webinar. Today's session is titled Fireside Chat on Patient Safety with APIC CEO Devin Jopp and Leapfrog CEO Leah Binder. Before we get started, I would like to go over a few items for our participants. Please note that this presentation is being recorded and will be available within 24 hours. We will notify all attendees once it is available in your APIC online education dashboard. APIC is not offering any continuing education credits for today's session. However, you will have access to the recording, evaluation, and participation certificate in your APIC online education dashboard after the webinar has concluded. We encourage you to submit your questions at any time during the presentation using the Q&A tab at the bottom of your screen. If you need technical assistance, please send us a message in the chat box or send an email to elearning@apic.org. APIC is proud to share that this webinar is available for live translation in over 25 languages through Wordly, which uses artificial intelligence for real-time text interpretation. You can read along in your preferred language on your computer or mobile device. To get started, click the link in the chat. This will open a new browser window. From the drop-down menu, select your preferred language and click Attend, and the program will begin to transcribe the live audio in the language you've chosen. Please note you may have to move this new browser to a second screen to view the live webinar as well. And now it is my pleasure to introduce our speakers for today's webinar. Dr. Devin Jopp joined APIC as CEO on December 7, 2020. He brings to APIC more than 2 decades of association leadership with a wide array of experience and accomplishments from across the healthcare and nonprofit sectors. He has been recognized as one of the top 100 most influential healthcare leaders by Healthcare Management International magazine and one of the top 50 healthcare IT experts by Health Data Management magazine. Prior to APIC, he served as CEO for the American College of Health Association and the principal leadership organization for advancing the health and well-being of the nation's 20 million college students and their campus communities through advocacy, education, and research. He has also previously served as president and CEO for the Work Group for Electronic Data Interchange, a national nonprofit advisor to the Secretary of Health and Human Services focused on enhancing the exchange of healthcare information. Before joining WEDI, he served as Chief Operating Officer for the Service Corps of Retired Executives, a national nonprofit organization that provides business mentoring and training to American entrepreneurs. Since 2008, Leah Binder has served as president and CEO of the Leapfrog Group, an award-winning national nonprofit based in Washington, D.C., representing employers and other purchasers of health care calling for improved safety and quality in hospitals. She is a regular contributor to Forbes.com, Harvard Business Review, and other publications, and is consistently cited among the most influential people and top women in healthcare. Ms. Binder has a bachelor's degree from Brandeis University and 2 master's degrees from the University of Pennsylvania, one from the Annenberg School of Communication and the other from the Fels Institute of Government. She lives in Maryland with her husband, Sam, and 2 children. Devin and Leah, welcome to the program. The audience is yours.
Thanks so much, Molly, and always a pleasure to be here with my great friend, Leah Binder, and it's just been such an awesome time when we get together and do these fireside chats. So thanks again. So we're going to go ahead and dive straight in. We're going to do a little bit of a back and forth in terms of asking each other's questions and kind of responding back in kind. So we thought with March 11th, 2020 coming up, which is the anniversary when the WHO declared the COVID-19 pandemic, we thought maybe start off with the opening question is, what have we learned about quality since? And so Leah, I'll turn it to you to kick us off.
Well, thank you, Devin, and it is always a pleasure to join you, and I'm really looking forward to a rousing conversation. I think when you and I get together, we always have some really great conversations and ideas, and it's really important for all of us that we have this opportunity to get together and really think broadly about this incredibly important mission that both of our organizations have, because we've got a lot of challenges ahead, but we also got a lot of opportunities, and we've got amazing people behind both of our organizations that I think can really make a difference. So I am very excited to join you today. I have reflected on the pandemic, and I'm not going to answer the entire question you just asked about what we've learned about quality, because that's a long answer, and I won't bore everyone with my many reflections on that. But I will say this. we did see a major problem with patient safety that emerged during the pandemic, which to my mind is alarming. We saw certainly hospitals under enormous strain, and we know that this was extraordinarily difficult for hospitals to manage through, or for anyone in the healthcare delivery system. But hospitals in particular were really on the front lines, and we saw that strain. And what came out of that strain was maybe not the best way of caring for people in a safe way. So what happened was, as we look at the data at Leapfrog, we've looked at the data throughout the pandemic, and we've seen a very alarming increase in hospital-acquired infections. So not the COVID-19 virus, that's a separate issue. People came into the hospital, perhaps with COVID-19, but in need of treatment, and they were much more likely to acquire a hospital-acquired condition, and those infection, and those we know, everyone on this call for both of our organizations knows, can be excruciating, and can be deadly. So that's very disturbing. We think that what we want for the delivery system in the future is that they are ready for the next public health emergency. We want to feel like hospitals are the repositories of the greatest expertise in the world on healthcare, and therefore would know how to handle a public health emergency better than anyone else. We didn't see that, certainly with regard to infection prevention this round. And let's hope that we've learned from that. And that's actually the question I want to ask back at you. Did we learn how to be ready for the next public health emergency, particularly around preventing infections?
Yeah, thanks, Leah, and great thoughts. And, I think in some ways, maybe we are, but in many ways not. And I think you said something right on, which is about the stress in the system that we saw with COVID-19 and that we just weren't ready. And, and I think, ultimately hospitals and any kind of healthcare facilities are high reliable organizations, or they need to be, right? It's like landing the aircraft on aircraft carrier. You can't just lose one every once in a while. And so I think what happened was, we thought we were ready, but we really weren't. And so when we came in, and I still think we still are feeling effects with things like supply chains, even now, where we're multiple years past. After we came out of the pandemic, we actually created a report on this that looked at, we called it Between a Rock and a Hard Place, lessons learned from the pandemic, and how to balance patient safety, because this issue of how do you make sure that you have this constant state of readiness during peacetime where you can address HAIs, and then when we do get changes in the ecosystem around us, i.e. a new pandemic, that we don't start losing patients to HAIs because we're busy worrying about the pandemic at that point in time. So, like I said, I don't know. I'm less optimistic that as a nation, we are ready to face another pandemic. But I think there are some things that we have to pay attention to. And so it's a little bit of a mixed bag, I guess, is my answer. A couple areas where I do think there's more need is certainly around like data and surveillance and doing that in real time. The National Health Surveillance Network and some of the data modernization work that is really important. We continue that work. And I think, the other areas, certainly we talked about misinformation. And I think that really was a critical piece that we saw. And we're still struggling with misinformation coming out of the pandemic. So, while HAI rates have improved since the pandemic, I think that whole issue about how do you harden the system and really change it, I think is an important part of what we've got to really struggle with together and keep that vigilance, if you will, for the next go around.
That's a very important point. I think the other key issue, and I remember you and I met actually at the height of the pandemic. I think we had a meeting via Zoom in like July or something. At the moment we were all grappling the most with just trying to figure out what to do. But what was disturbing to me was to hear from you that you had heard from your members that a number of hospitals, among the first employees that they furloughed, if you remember, they were furloughing a lot of people in those beginning days, were infection preventionists. During the worst, public health outbreak of a viral infection, certainly in my lifetime, the first ones to go on furlough were infection preventionists. That was really disturbing. It suggested that that perhaps the priorities were not appropriately aligned for this public health emergency.
Yeah, and you hit it spot on. And I think it was really incredibly sad and distressing to us to see that, when hospitals were tightening the belt, they're getting rid of the very people that design and implement the systems, the processes, the training to keep our patients and healthcare workers safe. And it made no sense to me at all. And I think we continue to struggle with making sure that hospitals are properly staffed, and I should say other environments as well, like long-term care nursing homes.
Right.
But, trying to make sure that that's top of mind, and even in our public health that we're doing funding for those at proper levels are really critical pieces. So thank you for pointing that out. It is definitely another difficult one that we've had to continue to try to message on.
Well, I think the knowledge that infection preventionists bring to healthcare delivery is absolutely critical, and especially during a public health emergency, but really all the time. And they need to be at the center of everything that's happening in a hospital always, as far as I'm concerned. I guess I can't imagine how you can run a hospital without absolute vigilance and top expertise on infection prevention, because that's such a danger to patients and to the workforce.
Well, I remember you when I first met you and I were talking about how Leapfrog is probably one of our biggest advocates for infection preventionists, right? Because ultimately what you all do critically drives patient safety. And when we think of patient safety, I think you always agree that infection prevention control rises to the top as one of those core issues that people think about when they think about patient safety. So one of the questions I have for you, Leah, is kind of how is both of our organizations, but maybe starting with Leapfrog, working to advance patient safety?
So our approach around patient safety is from what I would say is sort of the outside in. So our organization was founded by employers who are not in healthcare. So it's a number of very large employers with logos, like GE and Boeing and GM, automakers, just a whole variety of very famous large companies. And they purchased their own, health benefits. When large companies purchase health benefits, some people don't realize they actually are directly paying for each claim. Now, there is a third party that comes in and actually processes the money changing hands, but they are paying. It's coming out of their bank account when any employee has a claim. So they have a lot of concern about what's the value for that investment. They want their employees to get good health care. They do not want their employees to suffer from a preventable infection or an error or an accident. They don't want that to happen. And they certainly don't want to pay for that. So they were very concerned about reports that were coming out. This was back in 2000 when Leapfrog was founded. They were very concerned about reports like To Err is Human from the Institute of Medicine at the time, now the National Academy of Medicine, that said that 100,000 people a year were dying of these preventable errors and accidents. And some of these founders, like prominently Bruce Bradley from GM, took out a napkin and did some numbers and said, my God, that's like one GM employee every other day. Or retiree every other day. These were real numbers. These were not just numbers, actually. They were human beings that they cared about, that they were paying to get good care and not always achieving that. So anyway, so they founded Leapfrog with the goal of publicly reporting how hospitals in particular then were doing in preventing these errors and accidents, and making that information available to their own employees, but also to the public at large, so that people would make good decisions about where they sought care, and so that they had a conversation directly with hospitals to say, well, we notice you have a high infection rate, let's say central line infection rate. What are you doing to prevent it? What are the steps you're taking? They needed to have that direct relationship with the hospitals, not through their third parties, such as a health plan, but directly with the hospitals, because the hospitals were doing things that were very important to them. So what we like to think of for our role in patient safety is really the first domino. We're trying to galvanize change that will happen, but we're the first domino by saying we're publicly reporting it. We're bringing employers from outside to the table to say, this matters to us. So when we look at something like the role of infection preventionists, we see an extraordinarily important player in the dynamics of our healthcare system, and we want that player elevated to the highest levels. Because we recognize that is an extremely important function, and so our role is to shine a light on what you do, and make sure that you are properly prioritized in delivery of care, and to bring the employers to the table to put that pressure on health systems to put the priority where it belongs.
Mhm.
So
Yeah, no,
tell
yeah.
me, go
Go
ahead.
ahead.
Just tell me, what do you think that is helpful to infection preventionists? Are you seeing any resonance to the idea from communities and from the business community and others outside the hospital that it matters to infection preventionists to have that kind of recognition of their importance?
Yeah, it's first off, thank you for being champions for infection prevention and bringing that important voice. I total sideline here. I remember you guys first got founded. I think we coming up on your 25th year anniversary, and it has been a game changer in public health in terms of making sure that we have accountability. And so I think all politics are local, as they say. And I think, when you get into our IEPs and our facilities, right, that's where sometimes it really makes a difference, and sometimes it may not. And I think what we see is that keeping that pressure on is important, I guess, is kind of what I would continue to say. When you get into the culture of these organizations, where I think the ratings and other external factors kind of come into play, there's that reality of that the infection prevention team sometimes plays, they're not getting the credit when it's zero, right? Zero HAIs is not as difficult to sell, but it's so important. And so helping executives understand why that's important, and that it takes humans and the technology and the processes and all of the support and resources to make that happen is important. And so I think, our role at APIC in driving that patient safety piece is making sure that we have, highly trained infection preventionists that are in these spaces, and then giving them the tools they need to be successful, right? The best practices, the policies, the guidance, the education that's needed in order to make sure that they can get in there and then play the job. And I often say a lot of times the IP is like the invisible quarterback, right? They're leading from the middle of the organizations, trying to make sure that people know what they're doing, that they're following hand hygiene compliance, that they have the things are being done properly in these facilities in order to make sure that, again, we're keeping patients, healthcare workers safe. And so I think there's when it works well, there's this beautiful part where, Leapfrog plays this component of transparency and making sure that the voice of the employer is there, and putting pressure down. And at the same time, there's hopefully a culture ready to catch this of excellence that then starts building and supporting around infection prevention control. My dream is that we could get every organization to look at it that way, because we find it kind of that dichotomy of organizations that, or when times get tough, going back to your earlier comment, why are you cutting infection prevention control when really you need to be doubling down on that, because it's the most, keeping patients safe is the most critical work that we're doing. So, it's an interesting dance between the role of external pressure, and then I think the other piece too, Leah, to focus on is this idea around infection prevention control being everyone's business. And I think sometimes, when you get kind of the external voice, they think, well, it's all the IP's responsibility, and that how do you build and support that culture of safety, I think is important. How do you really do that within the organization and make sure that it's indoctrinated across all of the employees evenly?
And how do you do that? Because we watch it from the outside, we look at the numbers. That's the easy part, really. How do you change that culture?
Well, I think survey and accreditation is an important part of it, right? I mean, clearly that creates accountability. And but I think one of the things from within that we see is certainly, having goals and objectives, and from the board down is important. And then including the IP in this process, and I think that's not leaving them in the back room, but bringing them out front, making sure that CEOs and executives know they're infection preventionists, they're including them in their meetings. In some cases during the COVID-19 outbreak, we had times where there were emergency response teams and the infection preventionist wasn't involved, which seems mind-boggling. But these are the things that we have to correct, I think, in these systems. But I think in hospitals that get this, they're advocating the proper resources. They're making sure that IPs are properly staffed. They're continuing investing in their teams. They're making sure that the training is across the board, right? And I think you have to be meticulous about continue to remind people of what they have to do. It's like hand hygiene compliance, right? And I know both Leapfrog and APIC share this critical importance on hand hygiene. You constantly have to reinforce this behavior. It doesn't just happen automatically. And so, I think these are some of the ways that really organizations can rally around this and build it in their culture. But it takes mindfulness and constant diligence. But what are some of your thoughts as well?
I would agree. It takes mindfulness and diligence, and that is hard. That is not easy. I think it sounds easy. I always say hospitals can do brain surgery, but they can't always do culture. That is much harder. It sounds like, well, of course, we all want to prevent errors and accidents. We don't want patients to be harmed. We want to prevent infections. Everybody wants that. We all agree on that. But when it comes right down to it, and you're busy and there's a lot of pressure on hospitals, both on sort of the grand scheme of things like reimbursement and, new policies from the feds and the state and all kinds of new rules from employers and commercial, and they're under a lot of pressure. And so so on a little larger scheme of things, I think hospitals can easily be distracted from the day-to-day nuts and bolts of keeping patients safe. It's very easy to get distracted. And then on the sort of micro level, which is the day-to-day work of people in that health system, that's the other that sort of translates for them to, well, I was just too busy. We were running around all day. One nurse had too many patients, and I didn't have time to wash my hands in and out of the room, or I didn't have time to double check something, or triple check the medication order, all the things that it's just routine things that you have to do without exception 24/7. It can get distracting when there are too many other pressures and too many other distractions around you. So I get it, that's what happens, and that's why it's hard, but that's also why it's critical that leaders put an enormous amount of effort and attention to the issue. It is not enough just to say, well, I'm going to give a speech. I'm going to say how important this is to me. That's not enough for a CEO. CEO has to walk the halls. They have to reward excellence. They have to not reward poor behavior, which is another problem actually that does happen, where there's people who don't wash their hands, but nobody wants to say that to the chief of surgery or something.
Mhm.
Those kinds of things are a problem. So all of those issues can be hard, uncomfortable, and they can't be done. They're not one-offs. They're constant, everyday vigilance. And when we look at hospitals that have achieved really the highest grades on our hospital safety grade, let's say the A's, consistently over time, that's what we see. We see leadership that has put a major priority and doesn't let up on it. And then we certainly see a committed, dedicated team environment and good culture. So all of those things are all critical and all difficult. And if you take them for granted, you're not going to get there. You have to make it an absolute priority. So, but I'm preaching to the choir here, I know, because I think that you and your membership have been champions for that, since your founding.
Well, thank you. And I think, it's spot on around, how do you really try to get this culture to be replicable, where again, you're doing this consistently. And that's where we started off with that example, of the high reliable organization. And, patient safety is all about high reliability. And if you cannot replicate it and stay diligent on these kind of processes and procedures and the trainings and all the components of this, quality doesn't happen by itself, right? And I think from an infection prevention control perspective, it does require kind of that champion component. So we're always very grateful for Leapfrog being such a great champion as well. And I think as I always look with your hospital grades, and who really is getting the A's, what did it take for them to get to that? And also really, and I know you and I've talked about this too, like watching the ones that have improved, and what does it take to really improve those scores and turn it around? And I know you've had some real success stories over the years that you've watched some of your folks that have gone from low grades up to A grades in their scoring. So maybe one of my questions is kind of what's some of the secret and the sauce that you've seen in terms of what those organizations recognized?
I think there's a couple things. One is that culture that we've been talking about, that it's a combination of teamwork and leadership and relentlessness to it. There's a relentlessness to hospitals that I see achieving high grades. This is all anecdotal, but it's still, I mean, I've spent a lot of time in hospitals and really tried to understand this. Relentlessness, when you talk to a CEO of a hospital that consistently gets A's and just has outstanding performance on all kinds of patient safety measures, not all, by the way, there's no perfect hospital. Not a single hospital in this country has gotten it all right. So nobody's perfect. But when you talk to a CEO of a hospital that's done extremely well, they always, without exception, the first thing they'll say to you is, well, we've got a long way to go. We've got, this is wrong and that's wrong. I gotta, we've got to work so hard to keep, they can get to 0 and they'll be still saying, oh, we could get a CLABSI any minute now. I just know it because we're not doing enough in this and that. I mean, they're relentless. They never, ever see themselves as high achievers, or if they do see themselves as high achievers, they don't see that as permanent. They see that as, we could topple any second. We have got to keep moving. They're restless, relentless. And that's, you get that from everyone when you walk around and talk to people and tour. Everybody's really focused on safety as a priority. So that, and that is what it takes to do a great job with this. And that saves lives. Like, let's go back to that fundamental issue, which is we have a major problem with patient safety. It's like 1 in 4 people is harmed when they admitted to a hospital, and 500 people are going to die of a preventable error during the time you and I are talking together. So this is a huge issue, and when you can put that level of focus on it, you can save those lives. So I think that's the relentlessness is really the first thing that I kind of see. The other thing that we've been there's a Michigan Healthcare Collaborative. It's part of the Michigan Hospital Association, and they actually visited a number of hospitals that had been doing very well on Leapfrog, in particular, gotten to 0 on some of the infections, and they wanted to visit themselves and sort of see what they thought. And they had really some fascinating observations. And one that I thought was really interesting was that they found in those hospitals that they visited that when nursing protocols were adhered to, and everybody was working hard to really enforce that, to make sure that nursing protocols were respected and adhered to, that seemed to have a real impact on safety. So that was kind of a new perspective. I do think that nurses are absolutely critical to patient safety. So I think they reinforce that view by talking about the importance of nursing protocols. So those would be my two general observations. What about you? What's your thinking? What do you see in high performing facilities?
Yeah, I mean, again, it goes back to probably being a little repetitive, but I think, certainly that culture that embraces it. I think, resourcing, I think is infection prevention control efforts, and prioritizing those is important. And I think, one of the things we released, for example, was a staffing calculator now for organizations to start calculating, like how many IPs do you need? But outside of that, how do you make sure that this is being, the trainings are being done, and EVS workers know what they need to do, and that they're actually doing what they thought they were going to do, or the policies, procedures are in place and are being followed, or going back to your example, hand hygiene, right? That actually it's being done consistently all the time. And so I think, and in fact, one of the things we released this year was also that new patient hand hygiene toolkit, for example, to try to help even patients be washing their hands, right? But I think it's really all of these points together require kind of that diligence around, and I think organizations that do it well, you just see this constant, to your point, it's relentlessness around make sure that infection prevention is there. Our members always like to say at the table, and that they're being included and really listened to in the organization. And so, when organizations look at IP as a punishment or as the police, they're not going to be getting A's on Leapfrog surveys, and I think, they really need to embrace infection prevention in the core of their organization. So I think that's one of the things that we have seen is really that idea of adopting it into the makeup of that organization and being focused on it. So
how do you think technology has helped with hand hygiene or any other infection prevention and control activities?
Well, I think certainly it plays a critical role. I mean, I think certainly for organizations that can afford hand hygiene systems and have deployed them, they have seen very good results with those in terms of compliance, right? Because you have, and let's face it, that's kind of first generation AI when we talk about artificial intelligence, right? Is watching people wash their hands and having technology provide information on it. People that use the systems, I think, have had very good results with them. We also have seen, of course, technology in terms of data analytics, right? In terms of being able to watch with National Health Surveillance Network or even locally in their own EHRs, using analytics to determine, what's actually happening, and what are the trends that we're seeing, or in some cases, even tracking outbreaks between facilities, and looking at data patterns. And IPs play a critical role in that piece, making sure that, they've got their finger on the pulse. And there's always this kind of dynamic tension between, how much surveillance and reporting, and then how much are you on the ground actually, rounding and being with the patient and watching what's actually happening in the facilities. But all of those are important parts, I think, of how we're using technology. And I think, I think it's just beginning. I think, we continue to see some of the other technological advances coming up down the pike and expect much more ahead of time. But I'm kind of curious, what are you seeing as well, Leah, from your side of the house?
Well, we've become very interested in AI, and that's a term that everybody disputes of what that means, but the sort of new advances. And we've been interested in how that can be applied and is being applied for patient safety. Right now, I don't see it happening all that much, but we are seeing lots of discussion of how it can be, which is good. We also have a concern that it will be deployed badly. So it will not necessarily be used for patient safety, but it'll be used for things that you don't think are as important, or for the convenience of people who are not patients. So for instance, I've seen one application of AI that was used as almost like a bot that would answer physician in the middle of the night, or so the physicians don't have to do call in the middle of the night. And I was not impressed. And I think it was the example was given of a mom calling the pediatrician at 3 o'clock in the morning saying, my 3-year-old swallowed I think it was a dime. What do I do? Do I have to go to the emergency room? And the bot gave like a 3-page answer, all these clinical ideas. And I'm thinking to myself, as someone who's been that mom in the middle of the night, maybe not that exact example, but certainly scared and nervous, and really wanting at that moment to talk to a clinician, what a nurse or a doctor, but a person who is knowledgeable and also skilled at hearing my voice and calming me down and helping me make good decisions. That's not a good use of AI for right now anyway. And so I want to make sure that, that we're thinking about AI and we're pushing, frankly, to make sure that all of this new technology is used for its incredible potential for preventing terrible things. It can prevent infections. It can identify pathogens faster. It can prevent falls. It can even prevent. I've been hearing about how it can be used to prevent violence in the against the workforce, just by being able to detect when a patient is overly agitated or something. I mean, I just think there are so many applications that will keep everyone safer. And those should be the priority, but it's going to be up to both of our organizations to really put that pressure on.
Yeah, and I'm glad you bring that up. And I think you're right about kind of there's a lot of smoke and, how much sizzle is there really right now. But I think over time, I think hopefully it makes life easier and it keeps patients safer. I think there's like some things that the AI, that the tools have to be able to do. And hopefully even helps in terms of being cost effectively to be deployed. And I know one of the challenges among our members we hear is for smaller organizations, critical access hospitals, or RIPs call themselves oneers. If there's one IP in those facilities, is how do we make sure those technologies are available to even those organizations as they come online and can make a difference? So I think one of the things that I'm eyeing this on, and maybe the call out to everybody is, I think AI being able to take large data sets and come up in divine kind of new insights is going to be critical. And like things like clinical decision tools, where, yes, we have all these records for all these that you can get from all your specialists you've ever had for your whole life. But at the end of the day, they want to know your medications, your allergies, and your family history. But AI has the potential to comb through that and find out, oh, wait a minute, these things were reported here, or might be important for us to remember in the case of when we're rounding with the patient. And so I think the future holds lots of applications, but it's going to come back to, again, how do we triage these? And as you said earlier, with particularly health systems under financial stress, making sure that they're able to adopt them and actually makes their life easier or more cost effective.
I think with regard to critical access and rural hospitals, or even just smaller hospitals in general, I think that one potential will be the ability to perform many functions remotely. So to have functions, for instance, that can monitor patients from afar, or that can alert staff that there's an issue going on in one room or another. I mean, I think there's potential that would allow people not to be transferred out of a critical access hospital right away, or out of a rural hospital, because some things can be done remotely that couldn't be done before. So I think there's some potential to make things better for rural facilities. I hope there is, because I think it's been very disturbing to see so many rural hospital closures and just less access for people in rural areas. So I think I think hopefully this technology will be deployed to help make it easier to have a remote facility.
Yeah, it'll be interesting to see. And I think, certainly, while we've been focused on acute care, I think certainly home health and some of the other changes that we're seeing are there's opportunities. There's also inherent challenges and risks, particularly with infection prevention as we look at that. So, but maybe
Right.
my question for you, Leah, is, what other trends are you seeing in patient safety?
Well, I think that so AI is one. That's a big one that we're seeing lots of innovation and ideas about how we can deploy it. I think there's been a lot more focus on prevention of infection. So that's a good thing, especially since as I mentioned, the data that we've all looked at that shows the spike in hospital-acquired infections was so disturbing during the pandemic, and now we're seeing that improve. So that's a very exciting and positive finding. Hopefully that'll improve even faster, but it's going pretty quickly now. So we're very pleased with that. So I think there's been a lot of focus on that issue. There's also a lot of interest in public reporting for not only hospitals, but other kinds of facilities. So Leapfrog is working with ambulatory surgery centers and outpatient surgery as well. That's been a fairly new initiative for us since right before the pandemic. But I think there's also now, you mentioned earlier, a lot of interest in other facilities monitoring their safety in more granular ways, such as long-term care facilities, a big one, since they were the heart of so many problems with infection and with safety during the pandemic. So I think there's also interest just in general, though. There's so many other settings of care that are important, whether it's urgent care or physician practices, or, there's just all kinds of new settings. Even CVS now, have their own clinics, or all kinds of retail facilities. There's a lot of new shapes and sizes to delivery of healthcare, and all of those are going to come with some very critical issues around patient safety. So there's been a lot of interest in exploring how those can be looked at. So I think those would be the trends that I'm most seeing. But I think fundamentally it's about this recommitment to patient safety as a priority. I think that would have to be the fundamental trend, because we saw, for instance, that the President's Council of Advisors on Science and Technology, which is a White House initiative, came out with a report advising the president to put a real focus on patient safety. CMS has put out a couple of papers in medical journals saying patient safety has to be the priority. So I think there's been, and ARC is a big initiative. We're seeing a lot of action sort of at the federal level in particular around safety. And I think just that recommitment around it, which I think is very positive, of course. And hopefully we can take full advantage of it, for us and for you. We've all got to work hard to make sure that we take advantage of this moment when it's in the spotlight.
Yeah.
What do you
Yeah, well, it's thank you. And I think second, I think many of the things you just said, and I think going back on the kind of decentralization of healthcare, and I think, this idea of home health is it's got its pluses, but it also has its minuses. And I think, in some cases, health systems are looking at it saying, oh, wait a minute, we can reduce HAIs by keeping patients at home in their natural environments. But with that comes all kinds of issues right around, and it gets back into equity even, right? Not all homes are right, are clean environments and have caregivers to support them. And I think, how do you do rounding when you have thousands and thousands of patients staying at home? And I think the remote component of that is part of the solution, but not all. And I think as we grapple with that as a system of care, how do we make sure that we have the proper deployment, but not over utilizing technology where it's inadequate. So I think that's one. I think, a big one we're focused on is workforce development. And I think particularly is a big area and gap. And we've got 40% of the IP workforce that's entering retirement age in 10 years, which is super scary. And so we've been working on this year rolling out our IP academic pathway, and the Department of Labor just announced a new national IP apprenticeship program that they're partnering with us on. So we're trying to make sure that we can not only fill the tank up with new IPs coming into the field, but also as that need expands, because we're finding IPs in different settings now. For example, I was meeting with a couple recently that were doing IP work in veterinarian clinics. We have IPs in school dealing with school health. We have, infection control officers on cruise ships. And so, it's expanded even beyond the four walls of the hospital. And so filling that's going to be important. And then I think just a couple other areas, I still worry very much about kind of misinformation. And I think, whether it's from PPE to vaccine hesitancies, I think those continue to be huge trends and issues in public health and public safety, patient safety, that we have to really get our heads around and come up with some real solutions. So a lot for us to focus on and do collectively.
Right. And really part of the misinformation issue, or just one of the components, I think, is this issue of trust and building trust between providers and patients and the public in general. And who do you trust and how do you trust them? So I think being as transparent as possible about what's happening in our healthcare system is going to help that. But to your point, it sadly can go sideways when social media gets involved. Somehow things have gotten very, very difficult and I think in some cases dangerous. So we really do have to work together to make sure I think transparency absolutely has to be the number one thing, though. I think when we look at research that we've done to understand how the public perceives issues in healthcare, one of the things that's just always striking is you can say to a patient, like when we're testing them, you can say, well, this hospital had a big problem with objects left in after surgery, something that's to me like a total nightmare. And the patient or, the public, just a consumer will say, oh, that can happen. Wow, that's terrible. They think it's pretty awful. But if you say to them, the hospital's not going to report on that happening, they're not going to publicly announce it, they get very upset. So that is where the emotion comes in. So it's very important not to be trying to hide things or just saying, well, it's going to embarrass some people, so we're not going to say this happened. I think the transparency is going to be the key to building that trust.
I couldn't agree more. And I think, that transparency, you can only change what right? And you reveal. And so if organizations aren't being transparent, then they can't improve. So I think that's where Leapfrog plays obviously a critical role in that identifying that level of transparency, and quite frankly, it requires it. So
absolutely.
One of the questions I had, maybe flipping the tune a little bit to talk about health equity. And I know both of our organizations are focused on that, but what are you seeing in terms of some core challenges and or approaches vis-a-vis patient safety?
Well, we started asking questions about health equity. I think it was 2 years ago. We started honing in on that in particular, asking hospitals if they were, and ASCs, if they were stratifying their quality and safety data by race and ethnicity and other factors. And we found that most were reporting that they were not doing that, but that some were. And we started to focus in on the health systems that had more experience looking at the equity lens of looking through an equity lens at their own data on safety. And we found that there's really not perhaps as much progress as we would hope in health systems on really addressing this issue, but they do find problems and they do find lots of inequities. When we ourselves started to study the issue using what data we could get, which by the way, the data is not it's not the best. There's some problems with the data, but we did have access to data through ARC of really millions of patient records. And we partnered with the Urban Institute to do a study last year on rates of certain hospital-acquired events or hospital-acquired infections and events that rates by race and well, it was actually by race and by whether the patient was Hispanic or not. And that was eye-opening because there was some very disturbing disparities. We put the report out, it's on our website if you ever want to look at it, but it's what that tells us is these were preventable problems. What that tells us is that, and by the way, the patients were, it could be patients within the same hospital with the same payer, typically Medicare, who had disparate rates of these hospital-acquired problems. So for example, pressure ulcers was one where we found disparity between Black and white patients. I think it was Black patients were 3 times more likely to suffer a serious pressure ulcer than white patients. So that tells us something's happening within the healthcare environment. It isn't that we can say it's, social determinants of health, which are important. But in this case, when we're looking at patient safety, we're looking at a problem that's happening within the 4 walls of the hospital, where we're going to need to look in the mirror to understand it better and really understand how are we not treating these patients with equity. And so I think patient safety is going to be a really critical issue itself in getting at some of the fundamental issues within the delivery of healthcare that are affecting health equity.
Yeah, and I'm glad thank you for doing that great work and that research. I've had a chance to review it, and it really is well done. And I think one of the things we've been spending time on at APIC, we actually have a health equity committee and are doing some research right now. And I think your comment is spot on around the challenge. Of course, is we know that health disparities exist, and we know that patients are going to present to hospitals with those existing conditions, but how do we make sure that, particularly like as from our perspective, infection preventionist, what can we do to help kind of understand the problem, use the data? How do we make sure that then we help kind of facilitate change and action and improvement? And I think there's a lot of what we don't know. And I think one of the problems today, particularly, is that, it's not required as mandated fields to report race, ethnicity, sexual orientation. And so it gets very hard to get the data to even know what you're dealing with when those data fields are optional. And it puts the onus on facilities to do the right thing, do the extra mile to collect the data. And I think, what I think we're going to find, when I first started talking about this years ago, I said, is health equity a problem in your facility? And it went from no to I'm not sure to yeah, but nobody wants to talk about it. And I think that in probably the latter is probably the answer that's there, and that's anecdotal. But I talked to one health system, very large health system. They said, our data shows that we have central line infection differences by race. And I said, well, what did you do about it? And they said, well, we're still evaluating. Well,
Yeah.
right, but that's got to eventually turn into action. And so I think one of the what's the role, and then how do IPs, which I think are critical champions for data and understanding what's going on, I think can be real partners in helping the C-suite and other leaders understand what they can do to help understand this and get at that understanding level, but then take action on it, which I think is kind of that next part, which you are also alluding to. So we have a lot of work to do in this space.
No, we do have a lot of work, that is absolutely true. Because the other thing too, that's difficult in being able to stratify the data and to recognize, to really look at data from the lens of health equity, is to collect the data correctly. There's a lot of incorrect ways of collecting, like for example, just letting the admissions staff kind of guess is a really bad way, but it's done a lot. I mean, where it's like, well, they look like they're Black, so I'm going to write that down. That's, that's not necessarily the case, or, people have different ways of identifying themselves. So there's actually a whole, in some health systems are doing a really good job of collecting this data. They actually have trainings for everybody who's involved in any admission, very extensive training in how to ask this question. So I think all of those things are going to be really important as we go forward, because we've got to recognize that this is a major issue, and you don't have good quality or safety if you don't have equity. You can't have both. You have not succeeded without equity.
Absolutely true. Well, maybe I know we got a couple of questions. We'll take in a minute here, Leah, but maybe are there any other initiatives that Leapfrog or of course APIC are doing to enhance patient safety that you wanted to highlight?
I just want to mention one in particular, and you can always go on my website and take a look, and we've got lots of things going on, but we are about to launch a recognition program for hospitals that are leaders in caring for their patients with diabetes. And 30% of inpatients have a diagnosed either type 1 or type 2 diabetes. And those inpatients are at some substantial risk because they, in addition to just being at risk, because all patients have some safety risk that is major sometimes. In addition to that, if they're not getting their insulin properly, if they're not discharged with the right instructions, if the timing or the content of their meals is not proper, those kinds of things can actually have enormous consequences, and very frightening consequences for many patients who are living with diabetes. And so it's with the American Diabetes Association, we're launching this campaign to highlight those hospitals that are really following the guidelines, and we'll be awarding them in March. So stay tuned for that. And we'll be doing it every year. So hopefully we'll see more hospitals. We got a lot of applicants the first round. We want to get a lot more. We want to get hospitals to really focus on this. But it's just in general, I think it's important just for hospitals and health systems and of all types to be focused on what the different kinds of patients that we treat. And I think we really count on infection preventionists to help us understand the nuance of that, because not every patient is obviously not the same. And that's in part why this can be difficult to keep them safe. It's also why we need vigilance, and we need the great expertise of your members.
All right, thank you. Maybe a couple of things just to add in behind you on that on the APIC side. I think certainly one of the things we're rolling out this year at APIC is something called Policy Pro, and we're going to have an acute care version, which will include kind of what we understand to be some best in breed policies and procedures, which I think helps with best practices in facilities. We are also going to be rolling out a nursing home, long-term care version of those later this year, and also a ambulatory surgical center version in the following year. So those are one. And I think you guys heard me talk about the staffing calculator, and I know this is a question, so I'll hit it up in my comment. Is, the staffing calculator, we're kind of in version 1.0, and as we're collecting data, we're going to start releasing research on it and doing some further validation of our tool. And we will certainly be sharing all of the components within that calculator so everybody understands the variables and how we use them. There's no Wizard of Oz here in terms of how it's done. We want to make sure that we're being very transparent about it. But right now, we're still in that data collection piece. And I think another one, too, that's coming out that we're going to release in 2024 is we're trying to get together a 50-state state report card on infection prevention and control. And so our states being friendly to, is there legislation, regulation, encouraging these environments? And I think this is an area, Leah, you and I, probably next time we get together can spend some time on, but certainly an important topic. So.
And by state.
By state.
It's very important to monitor state policies around all patient safety issues, something we haven't been able to do as much as we'd like to. So we'll see what you're doing.
Absolutely. Well, I'll take some Q&A here and read them off. And I think one of them we got, Leah, was kind of a kudos, I think, and thanking Leapfrog for certainly their focus on hand hygiene and lowering HAIs and improving patient safety. So again, they were thanking for the focus on hand hygiene and help get the monitoring system accepted, paid for.
Well, thank you for your vigilance for a much longer time than Leapfrog has been able to get involved, for making this such a high priority. And so the way to get facilities to pay for this is to make it a priority. And it's just the same thing we were just talking about now. And I think that's a job that Leapfrog certainly can contribute to, which is to say to health system leaders, this is a high priority. That's what we tried to do with our hand hygiene standard, because, you know, I think it's Florence Nightingale who first said hand hygiene is a good idea. So that's a few years ago. We still aren't where we should be on hand hygiene. And that's one of the oldest, most really pillars of safety. So we need to get better, and we're going to push on it. And you push from inside, we'll push from outside. I think the technology may be aided by AI, by the way. There's some opportunities that it could potentially be aided and made less expensive by some of the breakthroughs in AI. So stay tuned, but let's all push.
Thank you. Well, and another question was in the chat, and it's in the hand hygiene category, but they said that APIC provides templates to convince your boss to attend the APIC annual conference, is what that might have been. Is there a possibility of APIC to outline a suggested template to propose for electronic hand hygiene monitoring that is endorsed by our large IP organizations? So we have a hard time selling this technology. So it's often the first to go. So it's one of these things where maybe there's opportunities in the future for us to work together on developing some components around that might help the business case, if you will, around you know, why these are important.
Yeah, that's a great idea. Yeah.
And that might be something, again, we can add to our list of things to kind of consider as we look in the future. Yeah,
well, that is a great idea. And it is going to be exciting to work with you directly, Devin, and your organization, because that's a perfect example of why working together, we can really make a difference. Because that's not something we could do on our own, but we can help make it work better when it's actually deployed. If we know if we're partnered with you, it'll help.
I agree. I think those are some natural areas where it's easy things for us to partner on. And in fact, I mean, and just so you all know, Leah and I talk all the time and trying to figure out how do we continue to partner, because I think it takes all of us to figure out working together to make it all work. One question we've gotten here that came in, it was, can you comment on eligibility restrictions for many IP positions? So many positions require an RN license when there's qualified IPs from other educational backgrounds. And this is definitely a big topic and one we face. And for the record, APIC is publicly endorsed that IPs can come from many different backgrounds. And I think, that's important, John, that we continue to be where we find the issue is particularly starts at the Department of Labor. We're trying to get a code identified for infection preventionists and talk about the backgrounds they can come from, because a lot of HR departments grab from the Department of Labor and how they define these. But we've got a lot of work to go. Again, a lot of these get stuck into the machinery of HR job descriptions, but we'll continue to be pounding it out there, the importance that IPs come from many different walks, public health, nursing, med tech, so on and so forth.
You've really taught me, Devin, about the breadth of experience and expertise that infection preventionists bring to the table, and the fact that they have a variety of backgrounds is such a strength to them, to the whole profession. So I am actually amazed to hear what you just said about the Department of Labor, that we don't actually have a defined role, or that's terrible. That's right there is a good example of where patient safety falls through the cracks, because we don't actually we don't say this is the centerpiece, this is who's accountable, and this is the advantage. I mean, when you don't identify who the people are and where they come from, you've missed a major part of the workforce.
Absolutely. Well, we had another comment here kind of supporting that their organization has embraced the different backgrounds, and it definitely helps as well. So I think we're at the close of time here, but Leah, any final words before we close out? And I'll add in
No,
behind
I
you.
just want to thank you and everyone watching this. Certainly I thank my own constituents, our employers who've been really so vigilant about safety, but also your members and for their leadership. It's a reassuring fact that they are out there really fighting an important battle, and your patients do appreciate it. I say that on their behalf. Thank you.
Oh, thank you, Leah. And again, we're so grateful for the support of Leapfrog and your members and employers, and just keep pushing that. And thank you for the amazing support, and thank you to our immense IPs. You are incredible, and we love you. Appreciate everything that you do. Even though some days it's harder than others, I'm sure, to kind of push organizations forward, but your work matters. So before we close out, I'm going to pass this back to Molly to close us out with some admin items here.
Thank you so much, Devin. Thank you, Leah and Devin, and all of our partners at the Leapfrog group. We really appreciate it. I did drop the link to our upcoming webinars as well as some of Leapfrog's upcoming events in the chat. And I'm just sharing very quickly how to access your resources. So within 24 hours, you will be able to access the webinar recording, evaluation, and continuing education certificate. In this sense, it'll be more so a participation certificate by logging on to your APIC online education dashboard. And very briefly, want to just highlight some of our upcoming webinars. Thank you again so much. Have a wonderful day. You may now disconnect.
Thank you.
Bye-bye.